Welcome back to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. Today's example is an 8-year-old bull mastiff with left front lameness and pain on palpation below the elbow. Here I will give you a chance to look at the radiographs. The client has provided a lateral radiograph of the affected left elbow, shown here, a craniocaudal radiograph of the affected left elbow, shown here, and they also included a lateral radiograph of the unaffected elbow for comparison. Now, you'll recall that we've been doing the ABCDs and that I've been focusing on B for bone. I'd like to continue to do that, and I'll highlight the most important findings for B for bone in this case. Starting with the lateral view. You'll recall that I like to trace every bone on every view. I zoomed out to allow us to get a good view of the elbow. As you trace the cortex of the radius and ulna, I'm hoping that you noticed that the cortex becomes very indistinct here in the region of the proximal ulna, both on the cranial and also on the caudal aspect. Additionally, I see areas of radiolucency where instead of the normal trabecular pattern, like I see here in the mid-radius, we see disruption of the normal trabecular pattern and mixed lucent areas along with areas that have increased mineral opacity. These are findings of bone lysis. Bone lysis is one of our most concerning things when we're looking to categorize a lesion as aggressive. You'll recall that the rest of my list for an aggressive bone lesion is bone lysis, periosteal reaction, or type thereof, zone of transition, and rate of change. Last week we saw a smooth periosteal reaction. You may have noticed when you were tracing the caudal cortex that it extends out a little bit and almost looks smooth. I would encourage you to always zoom in on a periosteal reaction. Last week I talked a little bit about when I trace a periosteal reaction, if I'm going along the long axis of the bone more than I'm going sort of up and down perpendicular, I tend to call it smooth. Maybe you can see that as I zoom in, if I'm really tracing the edge of this periosteal reaction, I actually have to follow quite a few little craters and divots, as well as some sort of areas that are kind of pointed outwards. So for me, this is actually a mildly irregular periosteal reaction on the lateral view. Now that I zoom out, you may also be able to appreciate, even from a distance, after having zoomed in, some of the areas where that periosteal reaction does look just a whiff more irregular than one that would be perfectly smooth. I'm going to go to the orthogonal view. We want to look for these same categories, bone lysis, periosteal reaction, zone of transition, and rate of change on the other view. The more of these categories that I can satisfy on the more views, the more confident I become that I'm dealing with an aggressive lesion. How do you like the look of the periosteal reaction on this view? It in fact has an appearance of not only being irregular, but I would even categorize some of this as having a slightly interrupted appearance on this view. This view is rather oblique, making it difficult to see all the details as we saw on the other view. But one thing that we can appreciate on both of the available views is that this lesion is centered on this sort of proximal diaphysis of the ulna. As I finish B for bone, the next thing that I look at on a case is the joint, and the mnemonic for that is C for cartilage, but what we're actually talking about is the radiographic joint space. You'll recall that the radiographic joint space is that area of lucency between the subchondral bone, and the area looks lucent because it's composed of things which are of soft tissue opacity. So in the radiographic joint space here, we expect that there's going to be lucency related to the presence of the cartilage on the epiphysis of each of the adjacent bones, as well as synovial fluid, joint capsule, and any intra-articular soft tissue structures. Have a look at how this well-defined subchondral bone changes dramatically as we jump over here to what would be the trochlear notch of the ulna. So for me, this is an aggressive lesion because I've confirmed that there's bone lysis. I believe there's an irregular periosteal reaction. The zone of transition, I think we could agree, is fairly mid-length, I would say. It's difficult to sort of distinguish when the abnormal bone ends and the normal bone begins. And my last criteria, rate of change, is something that we would assess if we had multiple views. Once we're confident that we're dealing with an aggressive lesion, I then like to categorize it as affecting one bone or multiple bones. That's actually quite difficult in this case because we're unsure whether there's involvement of the adjacent humerus and the adjacent radius. Why am I unsure? Well, in fact, a lot of this new bone formation that we're seeing on the edge of the joint, and I'm just going to switch colors to make it a little more clear for us. A lot of this new bone formation that we're seeing on the edge of the joint is actually related to chronic arthritis. You can see that there's quite a bit of new bone formation, osteophytes and enthesiophyte, on all aspects of the joint that are making it a little bit more difficult than usual. I'll show you the lateral view of the other limb so that we can compare. Do you see how quite a bit of that new bone formation that we see is actually also present on the normal, or at least not currently affected with lameness right side? So this is going to make this an even trickier case for us to figure out. In my opinion, what we're dealing with here is a process that's centered on the ulna. What I'm very confident about is that this is an aggressive lesion. I believe it's centered on the ulna, so I would categorize it as monostotic. It's unusual for a monostotic lesion to go to the joint. So this has some criteria that overlap between a primary osteosarcoma and perhaps a primary joint-based neoplasm. Sampling would be needed for definitive diagnosis, and I would recommend sampling the bone as well as the joint fluid to determine which was the primary process and rule out the unlikely chance that this could be a septic arthritis. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.